Hello everyone, and welcome to the second part of this three-part series of SEMCD webinars from Dr. Abe. I'd very much like to welcome you to this webinar, which will cover the very important topic of the patient examination, as well as the key features which we need to ensure are incorporated into the custom tray design. These two topics are extremely important to understand and follow correctly, and we have the master here to explain how to do it to achieve the maximum success. So I'll just very short introduction today, because I would like to welcome Dr. Abe to give this presentation. I would like to thank him very much again for his time, because it's evening over there. So Dr. Abe, I'll hand it over to you. Thank you very much, and I look forward to your presentation.
Thank you so much. So general introduction, Carl. And first of all, I'd like to say coronavirus infection is going around all over the world. And are you taking care of your health, yourself? And are you staying safe at home? And are you washing your hands? Three requirements are very important to prevent the coronavirus infection. And there is a tough situation, everyone, but I hope things get better soon. So, and I'd like to thank Ivoclar Vivadent again for inviting me this beautiful webinar, and for giving me the opportunity to be able to speak to you today, entitled The Suction Effective Mandibular Complete Denture Combined with Biofunctional Prosthetic System. So first, I'd like to quick review of what you learned on the first webinar. So what is absolutely required for complete denture suction? My answer is crystal clear. So complete sealing of the denture borders. So Carl, can you look at me? All right. Oh. I'm sorry. Can you look at?
Yes.
Can you see?
Yes, sorry,
okay.
I was muted. I was muted, Dr. Abe, while you were presenting. Sorry.
Okay. So can you look at the denture?
Yes.
Yeah. Okay. So if you make a hole on the palate region with a bar, everyone said maxillary denture easily drops down. On the contrary, and also if a lower denture here, so the leaking spot is created on the side of the lingual denture border, lower denture will lift up. It's clear even to a child. So the principle of suction, regardless of whether it's a maxillary denture or mandibular denture, there is no instance where air breaks the seal. If the seal is not perfect in even place, that maxillary denture drops down and the mandibular denture lifts up. It's clear even to a child. And this is a suction mechanism that is comprised of 5 different types of closures. So I have been stipulating BPS underpinning knowledge and technology is paramount to learning suction effective mandibular denture. And this is a reward of suction effective mandibular denture. So of course, patients are very happy because without implant surgery, and we were doing a better job of helping patients. And also the cost effectiveness, very cheap. And finally, with your more satisfied patients, you will get more referrals. And I would say, if you handle patients according to my suction concept, you will get enough suction. The next one, this video was sent from Korea, Dr. No. Very, very strong suction, you can see. Okay, so today I'd like to talk about intra-oral examination first, and I will share my how to fabricate custom tray that is a key feature design needed to achieve mandibular suction. This is the intra-oral examination sheet that the minimum number of inhibitory factors are reflected in. And it's separated into anatomical risk factors indicated by blue arrows on the bottom table or on the top table, and intermaxillary risk factors in the column on the bottom table. So this technique, this intra-oral examination is made up with qualitative analysis, but not a quantitative analysis, no measurement and no formula. Because we are busy clinicians, so we don't have enough time to take intra-oral examination so long. So shorter time intra-oral examination is very important for us. And thanks to this copy, we will easily evaluate or assess or estimate if there is a possibility to achieve mandibular suction or not. And this sheet is the most important part of making sure we know where we are going, what we are promising the patient on the patient's initial visit. The degree of difficulty from left to right, written down from left to right, could fare poor, or as the tongue retraction, slightly back, further back, even further. So this case is a very favorable condition because a case in all regions in a case with all regions in a favorable condition can be regarded as an easy case achieving mandibular suction. All regions are good region, good. No poor checks. On the contrary, we sometimes encounter patients with a little bit difficulty. So this poor check, there are 3 poor checks. So we need the optional impression technique to satisfy patient without denture. I will show you my optional impression technique. So after that. So this case is very difficult, but we will be able to achieve mandibular suction if you use the optional impression technique using silicone putty. So I'd like to explain and detail the risk factors individually. So first, ridge form. This is a guideline of the American College of Prosthodontists complete denture edenulism classification. And it's a quantitative analysis because the lowest diameter is measured. Diameter of the alveolar bone is measured by the cephalometric radiograph. And they are categorized into type A, type B, type C, type D. Of course, type D, the most difficult case, no ridge, and no ridge mucosa. But I think many denturists and the clinical dental technicians are joining now. So don't worry, because the bone resorption can be felt by touch with your finger, because the mental foramen is located diagonally from the buccal side in a case with good ridge form, and across in a case with a medium form, and the mental foramen sometimes on the top of the ridge. It's light one is the most difficult case to achieve mandibular suction, no ridge, flat ridge. And as you can see, mental foramen opens, on the top of the ridge, and we can easily, so we can feel, so there is a dip on the ridge where the premolars used to be. Okay, let's move on to the sublingual spongy tissue. So from left to right, abundant, moderate, and unfavorable. please take a look at the, take a look at the sublingual spongy tissue behind the anterior ridge. And please measure the distance from anterior ridge to tip of tongue. So I think within 2 centimeter, please put a check in a good column. And the 2 to 4 centimeter, put a check in the fair column. And over 4 centimeter, put a check in the poor column. By the way, how can we observe that? Take a look at this video, and the mouth is closed, but then sublingual spongy tissue swells up behind the anterior ridge. If that happens, you find that in your daily practices, please put a check in the good column. If not, next what we are going to do is to push the sublingual spongy tissue with a ball instrument. And it feels very soft like a sponge. Put a check in the fair column. Next one, oh my gosh, no spongy tissue, flat ridge. So if you find that case in your daily practice, you won't be able to achieve mandibular suction because lingual sealing would break easily due to the lack of sublingual spongy tissue. Please put the check in the poor column. So let's move on to the room available at the retromolar fossa region. So in order to complete the compensatory closure here, so denture extension of 2 to 3 millimeter extension of the denture border over the mylohyoid line is mandatory. So then pull the tongue to the side, and please take a look at the space where the denture border extended down over the mylohyoid line. This case, a very, very large space to extend the denture border down. So you should put the check in the good column. But on the contrary, this case is very severe because the soft tissue, so hanging over the retromolar pad region, lingual soft tissue hangs over the retromolar pad region. So no space to extend the denture border over the mylohyoid line. So if you find that case in your daily practice, please put a check in the poor column, and you want to be able to achieve mandibular suction. Very difficult case. So because there is, the principle of suction is very easy and simple, there is no instance where air breaks the seal. And let's move on to the retromolar pad region. There are 3 different types of retromolar pads here. And the left one, a nicely pear-shaped retromolar pad that is constructed with fibrous tissue at the anterior half of the retromolar pad and posterior flabby tissue at the posterior end of the retromolar pad region. In the middle, so at the first sight, very beautiful. It seems to be a very beautiful retromolar pad. However, actually no fibrous tissue at the anterior half of the retromolar pad. So it's very difficult to seal the retromolar pad region without fibrous tissue. And the final one, light one, oh, it's a string-like retromolar pad, string-like, so very thin. And I'd like to give you, please pay attention 3 points, 3 checking points. First one is the presence of the fibrous tissue on the anterior half of the retromolar pad. And the second, size, large, medium, small. And other one is please check if the inclination angle of the retromolar pad. So flat, steep, flat, mild curvature, and steep curvature. Take a look at the models. So you easily understand what I said. Flat, and a mild curvature, and a steeply curved forward. the right side, this one is the most difficult because the denture easily slip away forward when biting. Another checkpoint is changed in the shape of the retromolar pad region from the mouth opening closing movement. So now I'm touching the fibrous tissue. So it branches because the fibrous tissue is present at the anterior half of the retromolar pad. And I ask the patient to close their mouth slowly. You may notice that only posterior part of the retromolar pad is deformed. So the small amount of changes in the shape of the retromolar pad region. So please put a check in the good column. Small amount, only posterior part will be changed. Unfortunately, this patient doesn't have the fibrous tissue at the anterior half, so all regions are completely deformed, stretched out, and plump and short in its closed mouth. But fortunately, this retromolar pad is large in size, and the inclination angle of the retromolar pad is not steeper. So I actually got the suction in this case. This case is most difficult because the string-like sinew string and the string-like string shape of the retromolar pad completely changed to the triangular shape in its closed mouth. You can see large amount of changes in the shape of the retromolar pad region from mouth opening closing movement. Please put a check in the poor column. Very difficult to achieve mandibular suction. Let's move on to the tongue retraction. So in general, 75% of edentulous patients retract their tongues gently, naturally. So 75%. And in type 1, so further, and in type 2, even further. From left to right, left to right. Okay. So tongue retracts slightly. Please measure the distance between the anterior ridge to tip of tongue. And within 2 centimeters, put a check in the good column. And this patient, the tongue retracts maybe 3 centimeters. So from 2 centimeters to 4 centimeters, please put a check in the fair column. And this is over for maybe 5 centimeters or 6 centimeters. So strong tongue retraction. Please put a check in the poor column. Okay, and take a look at the below slide video. Oh, sorry. Okay. Ask the patient to close her mouth, but tongue position didn't change at all. So her tongue is lower back position. So in that case, if that happens, you are going to find that case in your daily practice. You won't be achieve mandibular suction. Very difficult. So next, I'd like to move on to the explanation of intermaxillary relationship, intermaxillary risk factors. First one, jaw relationship. Class 1, class 2, class 3, and in general, yeah, the mucobuccal vestibule, lower mucobuccal vestibule is directly below the incisive papilla, upper incisive papilla in class 1, and the posterior in class 2, and the anterior in class 3. Occlusal plane parallel to compass line in class 1, and posterior part is tilted up in class 2 and tilted down in class 3. And So this occlusal plane usually goes to a half of retromolar pad in European and American people. But in for Japanese people, this line headed on distal 1/3. So bone structure is a little bit different. And the tongue position differs greatly, but please focus on class 3, tongue position in class 3. Usually, tongue position in class 3 is in the lower back position. Then sublingual denture border would be exposed easily. So the higher the class, the more difficult it's to achieve mandibular suction. Next, mandibular jaw position. So, anyway, please take a look at this video. You can hear tapping sound, one after the other here, because she has a premature contact on her left back. And I manipulated her mandibular jaw backward with applying slight pressure. So as you can see, she had a large discrepancy of approximately 5 millimeters. In general, and the habitual mandibular jaw position would be improved in the pin tracing phase or bite restoration phase, but in some cases, the habitual memory cannot be easily eliminated because it's engraved in their brain deeply. So eventually, air will get in on the side of the denture base and the lower denture easily lifts up because the denture easily shifts in opposite direction caused by the premature contact. So I firmly believe that the intra-oral examination is very important for everyone prior to clinical performance. So if the patient has 2 millimeter jaw position gap, within 2 millimeter jaw position gap, so please put the check here. Yeah, so within 2 millimeter discrepancy. So we will not have a big problem because it will be optimized with the occlusal adjustment when denture delivery. And over 2 millimeter or 4 millimeter, please put the check in this column. And then we may need therapeutic denture prior to fabrication of the final denture. And we sometimes encounter a patient who doesn't know where to bite and whose tapping points go all over the place. Then therapeutic denture is very effective to find the patient's own comfortable mandibular jaw position while using their dentures. So what happened in the older edentulous patients? So young people or healthy dentate people has a beautiful condylus and nicely curvature joint fossa. Very beautiful condylar. However, in edentulous patient, the condylar tends to be deformed and loosened in the flattening joint fossa. From time series, changes in the bone density of edentulous patient, the cortical bone tends to be loosened, and on the contrary, the cancellous bone tends to be exposed. So as you know, the joints will undergo structure changes when the occlusal loading force onto the joint is too weak or too strong. After loss of teeth, the joint, edentulous patient has a strong occlusal loading force onto the joint. And on the contrary, so patient can support only 1/6 to 1/10 of occlusal force that healthy dentate people can bear. So the strong loading forces onto the joint completely destroy the edenturous temporomandibular joint. How can we find the discrepancy on the intra-oral donation? So this is silicone appliance. It's called Camlac. It's a silicone tube, silicone Camlac. And to make the muscle get tired in a short time, the silicone tube is substituted. So you can purchase this silicone tube at the home center near your office. It's inexpensive. But I cannot recommend cotton roll because no effectiveness. Silicone appliance is very nice for us to make a muscle get tired in a short time, to eliminate or to reduce or to minimize the patient's habitual memory. Okay, ask the patient to relax always contact for 3 minutes. And after that, remove the silicone appliance. Oh, with suction. And be careful. So pay attention not to have the patient close together. Once lower teeth come in contact with upper teeth, patient immediately remember the habitual jaw position. And our operator manipulated her mandibular jaw backward with applying slight gentle pressure. Then to recheck the anterior clearance. Within 2 millimeters, you find within anterior clearance within 2 millimeters, put a check in the good column. Okay, next, temporomandibular joint function. So left condylar, right condylar is further from joint fossa, and yellow part is the ear canal. And on the contrary, right side, so it's a very normal temporomandibular joint. Ask the patient to open, close her mouth slowly, and please check if condyles are moving evenly or same timing. Okay, place your finger at 13 millimeters from the ear canal, and open, close her mouth. Then she has a slight deviation to the left, but no creaking sound and no crepitation. Then I usually put a check in the good column because a slight deviation doesn't affect the mandibular suction. So if you encounter a patient with unstable mandibular jaw position, I have already stated, patient doesn't know where to bite or whose tapping points go all over the place. Therapeutic denture with flat table is very, very, very effective to normalize their mandibular jaw position. Flat table is created with 50% resin powder and 50% talcum powder, baby powder, you know. So flat table would become softer. Okay, and after using therapeutic denture, so functional pass onto the flat table can be seen. Then, so if the patient is not satisfied with our therapeutic denture, we will be able to switch over to the implant over denture. So I have already mentioned the success rate of suction effective mandibular complete denture is 87% according to the investigation of the Japan Plate Denture Association. There is no 100% prosthodontic treatment around the world. there is no. So let's move on to the customer tray design for SEMCD. This is the most important part of make sure, you know, because once you fabricate a well-fit custom tray with 7 ideas enhancing suction effectiveness, you will be able to achieve mandibular suction. So I'd like to introduce my dental technician, Kyoko Kokubo. So we have been working together for over 30 years. But she is, of course, very talented to not only fabricate complete dentures, but also removable partial dentures and implant-over dentures. So first, I'd like to quick recap of the complete denture impression history. Okay, so in the 1940s, Dr. Swenson from United States of America published his first book entitled Swenson's Complete Denture. And he had edited in its sixth edition. After that, in the 1960s, Dr. Boucher, who was a follower of Dr. Swenson, changed his book name to Prosthodontic Treatment for Edentulous Patients. It's currently in its 13th edition. I was very surprised, from 1940 to 2020. So this book is still so popular among not only educators, but also students, dental students. However, many patients reported more significant problems adopting conventional denture using a compound impression technique due to the lack of suction, lack of retention. To overcome this problem, I developed suction mechanism and concept in 1999. And be sure, the main target of the conventional denture is muscle attachments. And target of suction denture is oral mucous membrane. They are different. So this is a comparison between a conventional outline of the custom tray and the suction denture one. So regarding conventional denture, the purpose of the conventional denture is to achieve better masticatory performance through extensive enlargement of the denture bearing zone. And main target is muscle attachments. So tray design is carried out based on the muscle attachments position. And preliminary impression is taken using stock tray covering on the retromolar pad with frame. And take an impression with pressure loaded method. On the contrary, the purpose of the suction denture is to seal the entire denture border with oral mucous membrane. The main target is oral mucosa. And the preliminary impression is taken using frame cutback tray with least pressure loaded method. Very different. So they differ greatly. So these are impressions from the same patient. So as you can see, the left one is a conventional type impression with pressure loaded method with stock tray. Tray covers on the retromolar pad region. So all regions are stretched out. Very beautiful. If you want to, if you were a dental student, and if you want to pass the dental examination, you have to take such a beautiful impression. But is it true condition? It's true intra-oral condition? On the contrary, this impression is taken according to the suction concept. So frame cutback tray. So frame on the retromolar pad region is removed to minimize the deformation of the retromolar pad region. And with least pressure loaded method, closed mouth impression. So the different concepts result in 2 different constructions, as you can see. Yeah, conventional one and suction denture one. So you have already noticed that the suction denture is smaller than that of the conventional one, because we always take account of the presence of the submucosal tissue that is directly lying on the muscles. So tray design is of course smaller than that of the conventional type. And conventional type, I'd like to highlight the myostatic outline, and that is a very, very basic conventional tray design. Here, myostatic outline. And as you can see, on your left, only denture and muscle. On the contrary, suction denture. So lots of gums and mucosal tissue and labial tissue and tongue. Very different concept. Okay. So I'd like to talk about a conventional concept first. Below the mylohyoid line, where the mylohyoid muscles are attached to. Next, vaccinator muscle. Oh no, sorry, a masseter muscle. Masseter muscle squeeze when chewing or when closing, when biting. And the final one, external oblique line, where the vaccinator muscles are attached to. So this outline is constructed with all muscle attachments in the posterior area. On the contrary, suction denture outline is very, very smaller than that of conventional type 1. So very important, keep in mind, sorry. First, follow the retromolar pad, On your right, this is a model, based on the frame cutback tray impression. Draw the line, so on the retromolar pad region. And the next, this is a sinuous ring. My mentor discovered, so it's called Dr. Someya's sinuous ring, we say in Japan. And the sinuous ring is avoided, regardless of whether it's visible or not visible on the model. I think sinuous ring is like a small frenum. And below the line, the most inferior point of the mucobuccal fold. Be sure not to draw the line on the external oblique line. Overexpanded if you want to achieve mandibular suction. Okay, let's move on to the lingual part. This is the mylohyoid line. It's a guideline, but not a true line. And please remember that mylohyoid line goes to the middle of the retromolar pad region in general. And take a look at the meeting point here, between retromolar pad and mylohyoid line. And the true line starts from 2 millimeters behind the meeting point, and it runs in the inferior side of the retromylohyoid mylohyoid line to the diffraction point of S-curve. So posterior tray design is always uniform. Take a look at, this is a video. So first below the mylohyoid line, and it headed on the middle of the retromolar pad, please be sure. And 2 millimeters back at the meeting point, and it starts from 2 millimeters behind the meeting point and runs in the inferior side of the retromylohyoid fossa region or mylohyoid line, and to meet the diffraction point of S-curve. Okay, so these are a comparison between the conventional type and the suction type. So these are models from the same patient. So be sure. So uniform, tray design is always uniform. It's a favorable ridge condition or unfavorable ridge condition. So very beautiful favorable ridge condition can be seen but tray design is always the same in the posterior part. And here, so flat ridge, but a little more pads covers and avoid the sinew swing, and the buccal denture border is drawn on the bottom of the buccal fold and the lingual side. So that is exactly the same as I stated before. Okay, and 7 ideas should be given to the custom tray to achieve mandibular suction, to enhance suction effectiveness when taking impression. First, a little more pads are covered with a denture base very, very thinly, and avoid the sinew string that is located at the buccal base of the retromolar pad, and a concavity should be created here. So here, concavity should be created, sorry. Okay, here. So that BTC point will be easily formed. And the bite rim should be placed in the middle of the ridge width, and a huge tongue space is needed, and concavity is created inside the area. And concavity is created also at the lingual porous surface area at the retromylohyoid fossa region, because of where the tongue compressed that area to complete the compensatory closure. And in general, the characteristic of the patient characteristics is optimized by changing the thickness of the denture border. If the patient has a severe ridge form, more thickness given to the sublingual region and buccal shelf region. But in general, slight thickness should be given to the sublingual denture border and the buccal shelf denture border. And if the patient has a shallow labial vestibule where the mentalis muscle is attached on the top of the anterior ridge here, a slight thickness should be given to the custom tray. These informations are very important to fabricate the custom trays. So I'd like to explain the process of the custom tray design. First, preliminary impression is taken, and especially lower impression is taken using frame cutback tray, not to deform the retromolar pad region or minimize the deformation of the retromolar pad. And then next, the bite registration, temporary bite registration is taken using centric tray, and caster mounted on the articulator using the centric tray bite. And next, so the custom trays with Nasometer M should be fabricated, but I think Nasometer M are not available in other countries, many countries. So if you don't have the Nasometer M, sorry. Okay. Oh, okay. Okay, so wax rim is very effective, but you cannot take a pin tracing performance. So this is the reason Nasometer M is highly recommended to you. And final impressions of taken. So when fabricating custom trays, occlusal plane is very, very important. So once you make even pressure when taking precision impression thanks to custom trays, you will be able to achieve mandibular suction because you make the even pressure toward the ridge mucosa thanks to this custom tray. The occlusal plane is usually, so occlusal plane differs greatly in class 1, class 2, class 3. Usually, occlusal plane is parallel to the compa line in class 1 and tilted up class 2. So occlusal plane headed to the top of the retromolar pad region. And in class 3, occlusal plane is headed to the so half or 1/3 of the major part of the retromolar pad. So it's very important, okay? So here I'd like to show you map of SEMCD management. So there are 3 different types of intraoral examination results. The left one, no poor checks. Very lucky for everyone because you will be able to achieve mandibular retraction if you perform according to my concept and the technology and my instruction. In the middle, there are a few poor checks. So you need an optional impression technique prior to fabrication, prior to performing the final precision impression. I will show you how to do that after that, okay? And this is a many poor checks. So if you find that case in your daily practice, it's impossible to achieve mandibular retraction. Okay, this is an easy case. No poor checks. Lucky for me. So some dentists ask the patient, convince the patient twice as much because the suction extra fee. You know, yeah, some dentists. Okay. So as you can see, so he has class 1 and clear anatomical landmarks and a stable mandibular jaw position. So actually, his denture were fabricated with only 2 patient visits, And also, this is a digital denture. So when I was a staff member of GC digital research member, but GC company gave up to manufacture, they gave up to establish the digital denture workflow. So, but it's okay. So I'm very associated with digital denture, but Carl is my teacher of digital denture. Okay, I'd like to introduce my patient. A very difficult case. So I think you will get many information from this presentation. So she was a 78-year-old female, and her husband and son are dentists, and they gave up to fabricate, gave up to satisfy her with their denture, and they referred her to my office. So she had 2 big problems of maxillary denture dropping and the mandibular denture lifting. So I'm sorry I didn't establish the intraoral examination of the maxilla because there's a small number of inhibitory factors in the maxilla. Okay, take a look at very beautiful flabby tissue. All regions of flabby tissue and small mouth. So let's move on to the intraoral examination of the mandible. Flat ridge, so no ridge. And so you have already noticed that. Strong tongue retraction, maybe 5 centimeters from the anterior ridge. Yeah. And no ridge. And the next, oh my gosh, small genial tubercle is here. And the mental foramen opens on the ridge mucosa, so where the premolars used to be. So very severe case. So let's move on to the intraoral examination of the sublingual spongy tissue. Then I have to ask the patient to close her mouth slowly and open, close, repeatedly. But unfortunately, no sublingual spongy tissue swells up behind the anterior ridge. No sublingual spongy tissue. So put a check in the poor column, poor and poor. Next, let's check the room available at retromylohyoid fossa. To pull the tongue to the side to check if there is a sufficient space to extend the denture border downward in inferior direction to the retromylohyoid fossa region. We can see, so you can see the sufficient space, but soft tissue sometimes raises up. So I put the check in the fair column, fair and fair, okay? And the next, retromolar pad region. So ask the patient to close her mouth slowly, and only posterior part of the retromolar pad here is deformed, and anterior part of the retromolar pad is not deformed. So because fibrous tissue is present here. And so in total, fibrous tissue are good, and the size is almost fair, so medium size, and the inclination angle is very steeper. And finally, thanks to presence of the fibrous tissue, the changes in the amount of the changes in the shape of the retromolar pad region from mouth opening closing movement is not large. So put a check in the fair. On the other side, oh my God, all regions are completely deformed. No fibrous tissue here, and size medium, and so retromolar pad inclination angle is steep. And finally, so all regions are deformed without presence of the fibrous tissue at the anterior half of the retromolar pad. So put the check in the pool. And let's check if she has a discrepancy between her habitual memory and the habitual mandibular jaw position memory and operator manipulated mandibular jaw position. Gold teeth. So because her son made these dentures. And this is the camera. Ask the patient to relax, always contact. To relax for 3 minutes. Okay, skip the time. Okay, after 3 minutes. Sorry. Doesn't work. Once again, I'm sorry. Next. What? Too early. Okay. Take a look at. And I manipulate her mandibular jaw backward a little bit with a gentle pressure. So she has a huge discrepancy of maybe 1 centimeter. So this failure caused by, I think, so vital restoration error. Next, let's move on to the temporomandibular joint. Oh. Yeah, okay. So her temporomandibular joint was very healthy, no problem, no crepitation, and no clicking sound. So this is a outcome of the intra-oral examination. So there are many projects. So no ridge form, so flat ridge form, so higher level lab work is mandatory. Oh. Okay, and models in the impression and the bite record will be delivered to the dental technician. And also, of course, together with the results of the intra-oral examination. Kyoko is a specialist to understand what I want to do. So this patient has a maxillary flabby tissue. So in order to prevent the maxillary denture from being dislodged, optional flabby impression technique is mandatory. And she had a poor retromolar pad shape, so extra sealing technique is required prior to the final precision impression. And this patient has a lack of sublingual spongy tissue and the severe tongue retraction. So to prevent the mandibular denture from being dislodged, so the optional sublingual sealing technique is essential. And she has a shallow labial, so optional labial expansion technique is mandatory prior to the final precision impression. So please take a look at on your left. So occlusal plane, check now we are going to check if occlusal plane is parallel to the compass line or horizontal line. And after that, denture base fit is not good. So please apply cold cure resin to make the denture base better fit, right? Because she has a soft retromolar pad tissue. So even with frame cutback tray preliminary impression, retromolar pads were a little bit deformed. And I place the denture and I pull the cheek inward and ask the patient to close together a little bit, yeah. And as you can see, there is a large gap between the natural retromolar pad shape and the tray shape. Can you see? And I mark the true line. And the excess part should be trimmed off to match the natural shape, of the retromolar pad with the tray denture base. Okay, and it's very important information for everyone. If the patient has a tongue retraction, the space is created here. Space is created behind the lingual denture border. Then optional sublingual sealing technique is very, very effective. So please use the silicone putty and ask the patient open and close. Be sure not to ask the patient to move your tongue forward, stick out, or side to side. Only swallow and open your mouth. Okay, so silicone putty is applied and make it flat, thinly, make it flat, and place it back to the mouth. And first, push the impression materials so that to fill the space with the impression material, and swallow. And hold the tray down, firmly down. Please wait 10 seconds. And once again, ask the patient to swallow. This is an optional sublingual sealing technique with silicone putty. If the patient had a severe shallow labial vestibule, such as this, on your right here, the thickness should be given to the labial denture border so that concavity easily created at the polishing surface, and it will enhance the maintenance of the rib support. Applied into the adhesive and the silicone putty. Very, very slight amount of silicone putty is applied. And I make it flat as well. And place it back to the mouth. So as you know, mentalis muscle is very weak muscle. So first, operator pull the lower lip up and make the concavity on the palate surface region. And ask the patient to swallow. So mentalis muscle acts only swallowing, only fan swallowing. And hold the tray down. And please wait for 10 seconds. And once again, ask the patient to swallow. Yeah, dental hygienist is very kind to pour some water because it's very difficult to swallow without saliva. Interior surface, impression material in the interior surface of the tray should be removed to avoid the over pressure, and the taper it and smoothen that. So we are ready to approach to take final precision impression. Okay, so after finishing border molding, the light bodied impression material is applied, entire surface, and spread out the buccal and the labial and the lingual evenly, and place it back to the mouth. And apply pressure by the operator fingers for 7 seconds until the tray will become is stable. And ask the patient 5 exercises. Ask the patient to make 5 exercises. Ooh, ee, ooh, ee. Hold the tray firmly down. And stick out the tongue and move the tongue side to side to capture the lingual floor movement. And close together and lock the chin and push the back side of the tray with her tongue and finally swallow. So 2 or 3 circles. Repeat 2 or 3 times. Okay. So this is the result of suction. So even with severe case, severe case, I got enough suction. So this is the final impression. So denture border thickness can be seen. Denture border thickness can be seen at the sublingual region, thinness at the retromylohyoid region, and the sufficient thickness can be seen at the buccal shelf region, and also labial part to enhance the lip support. So, but we sometimes encounter difficult patients. All regions are many poor checks here. Then, when doing a consultation with this patient, implants over denture is highly recommended. So finally, 2 implants are placed and the locator attachments retention. Locator attachments are set, secured. As a retention, right? Okay, sorry. So I'm sorry. So my personal PC didn't work well, but I feel relieved to finish this presentation today. And on the third webinar, I'd like to share my clinical performance from start to finish with analog and digital technology. So I hope you found my presentation was informative today. Thank you so much.